Today I will be presenting the data from my study investigating the impacts of communication impairment on the ability to participate in daily activities and psychosocial well-being in people with MND. Before I begin, I would like to acknowledge my supervisors and co-authors listed here for their support and guidance throughout my PhD. I would also like to give a special thank you to the Prince Charles Hospital Foundation for believing in my work and awarding me with a PhD scholarship. Dysarthria is one of the most distressing and debilitating symptoms of MND. While we know dysarthria to be an initial symptom in 25 to 30% of MND cases, 90 to 95% of people will likely experience verbal communication difficulties at some point during disease progression. Features of dysarthria include decreased speed, range, tone, accuracy, and/or steadiness of movements in the respiratory, phonatory, articulatory, and resonatory speech subsystems. Progressive impairment to one or more of these speech subsystems can lead to alterations in naturalness of speech and intelligibility, and eventual loss of functional verbal communication. Furthermore, we know dysarthria impacts communication effectiveness in people with MND, and therefore restricting the ability to participate in activities of daily living. Reduced ability to use speech or speech loss can therefore negatively impact on social interactions and vocational roles for people with MND. As living a passive or more isolated lifestyle leads to feelings of frustration, isolation, control issues, and negativity, people with MND are likely to experience an impact to their psychosocial well-being. However, no studies to our knowledge have investigated change in communication effectiveness and psychosocial well-being in people with MND over the course of the disease. Therefore, our study aimed to map the deterioration and changes in communication effectiveness and psychosocial impact of dysarthria in people with MND over a 12-month period from the early stages of the disease. The object of the study was to provide an understanding of the importance of patient-centered management for people with MND. A longitudinal prospective cohort methodology was employed for the study. Convenience sampling was used to recruit 6 people with MND from the MND clinics within the Queensland Health Metro North Hospital and Health Services. Participants were eligible for inclusion if they received a formal diagnosis of MND in the previous 6 months and were able to provide informed consent. Individuals who were 7 months post-diagnosis or later, or presented with a severe cognitive impairment, dementia, or other substantial medical, neurological, or psychiatric disorders, or were not proficient in English, were not eligible to participate. Participants were assessed at 5 time points at 3-month intervals over a 12-month period. Sessions were conducted either in a quiet room at participants' homes or at the University of Queensland. Each assessment session consisted of the completion of a perceptual clinician-rated assessment and patient self-reported measures. The ALS Severity Scale speech subsystem is an ordinal staging system that evaluates functional verbal communication. The clinician conducting the study rated participants on a scale of 1 to 10 using a conversation sample. 1 indicated non-vocal and 10 indicated no impairment to speech. The study M incorporates social situations relevant to people with MND. Communication effectiveness for 10 social situations was rated by participants using a 7-point Likert scale, with 1 indicating not effective at all and 7 indicating very effective. The Depression Anxiety Stress Scale is a 21-item self-reported measure used to determine overall mood. It includes 3 scales along the axes of depression, anxiety, and stress, with 7 items per scale. Participants rated the extent to which each state was experienced over the past week using descriptors correlated with numeric values on a 4-point scale, with 0 indicating never, 1 sometimes, 2 often, and 3 almost always. Severity of depression, anxiety, and stress symptoms was determined by summing the score for each scale and using the clinical cutoff scores. The dysarthria impact profile quantifies the psychosocial impact of acquired dysarthria from the perspective of the person with MND. The DIP consists of 48 items across 4 domains. Participants responded by ticking strongly agree, not sure, disagree, or strongly disagree to each statement or item. Numerical values were assigned based on how negatively or positively the items were worded. Then the total DIP score was calculated by summing the domain scores. Low total scores indicated major negative impact, while high total scores indicated minor negative impact. For the fifth domain, or domain E, participants were required to write up 4 concerns or worries in addition to their dysarthria. Thereafter, the concerns and worries were ranked in addition to speech difficulty from 1 to 5 based on level of concern, 1 being most concerned and 5 being least concerned. Descriptive statistics were used to observe clinical trends in data over the 12-month period. Due to the small number of participants, non-parametric statistical analysis was used. The Friedman's test was employed to test for progression, while significance was determined using a p-value of 0.05. Where significance was identified, post-hoc analysis between the first time point and subsequent time points, as well as interim time points, was conducted using the Wilcoxon-signed rank test. A p-value of 0.05 was used to determine significance. To identify the biopsychosocial impacts of MND on participants' functioning, open-ended responses from domain E of the DIP were mapped to the ICF, or the International Classification of Functioning and Disability, using a crosswalking or linking methodology. The steps of crosswalking involved identifying meaningful concepts in participants' open-ended responses of the questionnaire, mapping the concepts onto relevant ICF domains including body function, activities and participation, and environmental factors, and coding concepts to more precise ICF categories where possible. Responses that did not fit within the ICF were provided their own code. Items were only coded once, and accuracy of coding and categorization was checked by 2 other team members and speech-language pathologists. At baseline, we see a median score that demonstrates obvious speech changes for the group. Furthermore, a significant reduction in functional verbal communication was observed over the study period, with median values for each time point showing a gradual decline over time for the group. However, the range highlights that not all participants experienced a reduction in their verbal communication. Post-hoc analysis revealed a significant change to functional verbal communication within the first 6 months of the study, and that changes in functional verbal communication occurred within 3-month intervals throughout the 12-month study period. Mild to moderate impairment to overall communication effectiveness in the early stages of the disease was observed, with deterioration of overall communication being significant across the study period. By the last time point, communication effectiveness became moderately to severely impaired. The ranges across each time point indicate all participants experienced some level of reduced overall communication effectiveness, despite 1 or more participants having functional verbal communication. Post-hoc analysis baseline comparisons revealed significant decline in overall communication effectiveness within the first 3 months of the studies and subsequent time points except time point 5, or the last time point. Interim time point comparisons highlighted deterioration in communication effectiveness within 3 and 6 month intervals. Descriptively, communication effectiveness declined across all social situations over the 12-month period. Deterioration over the study period was significant for all social situations, with the exception of having a conversation with a stranger over the phone and speaking or having a conversation before a group. It is important to note that the median scores at baseline indicate communication effectiveness while having a conversation with a stranger over the phone and before a group were mild to moderately impacted, with ranges indicating 1 or more participants experienced a severe impact to their communication effectiveness while participating in these social situations. Median baseline scores revealed communication was most effective with a familiar person or stranger in a quiet room and over the phone with a familiar person. The score range for conversing with strangers in a quiet environment revealed that all participants experienced some level of reduction in communication effectiveness. Conversely, communicating at a distance and in a noisy environment were least successful, with communication effectiveness being moderately impacted at baseline, with all participants experiencing some level of difficulty communicating effectively in each environment. By the last time point, communication effectiveness while having a conversation with a familiar person and stranger in a quiet room and having a long conversation were the most successful, although still mild to moderately impacted. By the last time point, communication effectiveness was severely impacted while having a conversation with someone at a distance, in a noisy environment, and over the phone with a stranger. Post-hoc analysis baseline comparisons revealed communication effectiveness in 7 of the 8 social situations declined over the first 9 months of the study. Post-hoc baseline analysis revealed communication effectiveness deteriorated significantly while having a conversation with a familiar person over the phone and while having a long conversation within the first 3 months of the study. Furthermore, significant deterioration in communication effectiveness occurred while having a conversation in a quiet room with a familiar person and stranger, with young children, and in a noisy environment within the first 6 months of the study. Symptoms of depression, anxiety, and stress did not progress significantly. However, median scores indicate detectable symptoms of anxiety at baseline, while symptoms of depression were detectable at the last time point. At the 3, 6, 9, and 12-month time points, individual scores indicate 1 or more participants were experiencing either mild or moderate symptoms of depression and/or mild symptoms of stress. Furthermore, 1 or more individuals presented with mild, moderate, or extremely severe symptoms of anxiety across each time point. Progression of overall psychosocial impact of dysarthria was not significant. However, median scores reflect a moderate impact on overall psychosocial well-being throughout the 12-month study period. Furthermore, the ranges at each time point indicate that all participants, including those with functional verbal communication, experienced some level of reduced psychosocial well-being throughout the 12-month study period. Descriptive analysis shows dysarthria had a moderate effect on the speaker at baseline, with severity of impact increasing significantly over the 12-month study period. While dysarthria continued to have a moderate effect on the speaker at the 12-month time point, the impact ranged from moderate to major across participants. Post-hoc analysis showed a significant effect of dysarthria on the speaker within the first and last 3 months of the study. A total of 101 worries were disclosed by participants, with the most reported worries across body function, activities and participation, and non-ICF factors. Detailed worries are listed on this slide. Overall, our results support the need for holistic and patient-centered care. Early and/or rapid changes in functional verbal communication, communication effectiveness, and psychosocial well-being shown in the study indicate the vital need for early and continual engagement of speech-language pathology services. Furthermore, communication effectiveness is likely a key clinical marker needed to anticipate and track reduction in communication participation from the early stages of MND. Subsequently, an understanding of social situations facilitating or impeding communication effectiveness is important in tailoring management strategies with disease progression. As 1 or more participants with functional verbal communication presented with a reduction in communication effectiveness throughout the study period, it is likely factors beyond speech impairment are impacting communication effectiveness, such as hearing impairment and/or fatigue. Therefore, considerations of factors beyond dysarthria identified by people with MND need to be considered when providing communication management. Psychosocial well-being was impacted throughout disease progression for all people with MND, irrespective of dysarthria presence. Furthermore, domain E results from the DIP show worries in addition to dysarthria. Therefore, close monitoring of overall mood and psychosocial well-being is required to make timely and relevant referrals to members of the multidisciplinary team. Limitations of the study include inability to capture insight from MND symptom onset, and due to high attrition rates of people with MND, the study had a low number of participants. People with MND experiencing cognitive changes or frontotemporal dementia were also not included in the study, and while the study captured vital information on communication effectiveness and psychosocial well-being, the experiences of people with MND were not addressed. Therefore, it is suggested that future studies include a large number of participants, people with MND who have cognitive changes or frontotemporal dementia, and the experiences of deteriorating and/or changing communication effectiveness and psychosocial well-being throughout disease progression. Thank you for listening to my presentation today, and I am very happy to answer any questions on this forum or through the email that's provided on this slide.
My Thank you very much, Salma, for a really important study, I think. And I think it would help us to plan and anticipate problems that may arise for patients as the disease progresses. Are there any questions for Salma? There's one in that far corner. Salma, while they're just going to take the microphone, I just wondered if, and it's not something you might have thought, but men and women clearly often, I mean, I suppose anecdotally kind of communicate in very different ways. Did you notice any difference from your study between the men and the women?
It's hard to tell or talk about it because we only had 2 females and 4 males. So to get a good insight on male versus female presentation, I think we need a bigger number. But with that being said, part of my PhD or part of my research actually did have a qualitative component. And in saying that, the women did disclose that communication had more of an impact on them and the way they decide to participate in daily activities.
Thank you for that. We have a question from over there. Just changing the microphone.
Thank you for the presentation. I had a question with regarding to interventions. You followed the participants for a year. Were those participants intervention naive, such as speech computers, or did you took that into account as well?
Yeah, absolutely. So in this particular study that I presented, we did accommodate for take into account whether or not the person was accessing the AAC device. But at a later study that I did, we did account for the AAC device being used by some participants. Majority of participants in the study actually weren't using an AAC device, and again, during the interview process, all of them wanted to complete voice banking, but never did due to the difficulty of the process. So I think, and again, it's been a few years since I collected that data during my PhD, but I believe that it comes down to how much their allied health professionals knew and when to introduce certain types of interventions for them.
Thank you.
We have time for one more question. If there's any online questions? Nope. Lovely. Salma, thank you very much for your presentation.
Thank you.